Thanks for watching TMA's Legislative News Hotline for Sunday, July 2nd. I'm Brent Anir. This week's hotline is part 4 of our 5-part series recapping major issues lawmakers addressed during the 85th Texas legislative session. TMA Legislative Affairs Director Dan Finch joins TMA Communications Vice President Steve Levine in a moment to discuss the landmark bill to solidify the practice of telemedicine in Texas. They also covered what happened to some efforts to broaden scope of practice and sunset legislation to extend the Texas Medical Board.
Now we have with us another great member of the TMA advocacy team, Mr. Dan Finch. Dan, thanks so much for coming in to talk to us today.
Pleasure to be here, Steve.
Let's talk about an issue that for the past couple of years has been kind of messy here in Texas, and that's telemedicine. I mean, we have lawsuits, we've got the rest of the world thinking that we're in the telemedicine wasteland, something we know is not true, and we worked a really, really long time to put together something that we think now puts Texas at the forefront of telemedicine law. Tell us about it.
It is actually the culmination of at least 15 months of very hard work, not by TMA, not just by TMA, but by the Texas eHealth Alliance and the Texas Academy of Family Physicians, and a host of other stakeholders who participated in basically a process that spanned from January of last year that culminated in the governor's signing of Senate Bill 1107. And
Senator Schwertner was the primary driving force saying, I want you guys to come together and come up with something that everybody can agree on, right?
Right. Senator Schwertner was very instrumental in actually driving the agreement on the definitional side of the bill, which where we defined the establishment of a legitimate patient-doctor relationship in a telemedicine environment for the purpose of writing a valid prescription.
So some people probably think that now this means anybody with a webcam, any doctor anywhere in the country can start treating Texas patients, but that's not the way this law is going to work, is it?
We went into the discussions 15 months ago with 3 core principles. Number 1, that telemedicine is the practice of medicine, and as such had to be performed by a licensed Texas physician. Number 2, that we would base this all on standards of care, and it's the same standard of care in a telemedicine environment as it is in an in-person environment. And then our third core principle was to address some of the payment issues.
And at this point, at least, we've got Texas leading the way. I really think that standard of care issue is probably the key to it. So it means that if I've got to do certain types of exams or ask certain types of questions in person to reach a diagnosis to be able to write a prescription, I've got to do the same thing using telemedicine, correct?
The same standard that applies in in-person care applies in telemedicine care. We are actually relying on physicians to exercise good and proper medical judgment to render services in this environment, this new environment. But we're also asking them that when they do not have access to the clinically relevant information necessary to make a diagnosis in accordance with the standard of care, that they have to basically end that encounter and recommend that an individual seek in-person care from a physician or urgent care or even an emergency if that's what it amounts to.
Sounds like a good way to take advantage of this emerging technology.
I think part of the issue is how you view telemedicine, because some want to view telemedicine as the service itself. And if you look at it as simply the service itself, you can carve it out, bundle it up, and contract it out. Our view of telemedicine, and it became very apparent that others shared our view, is that telemedicine is simply a means of providing a service. It is, in fact, another tool in the doctor toolbox to provide covered services to insured individuals by contracted physicians. And I think if you look at the payment provisions in the bill, that is exactly where the bill ends up.
You've spent at least the past 10 legislative sessions, either here or out of Harris County Medical Society, dealing with scope of practice issues. That's something that really doesn't seem to change a whole lot from session to session. You have non-physician practitioners who are asking for legal authority to provide the kinds of services independently that, in our view and in the view of state law, require either the physician to do them or physician supervision. So we started this year with, I believe, a host of scope of practice incursions. How did we end up the year?
If by host you mean over 30 individual bills related to expansion of scope, you are correct. It is a perennial issue with the Texas legislature. Everybody wants to do what physicians do without doing what they've done, like go to medical school. We faced at least 2 different bills that required some degree of autonomy for nurse practitioners to diagnose and independently prescribe. But we faced other bills like bills to allow psychologists to prescribe. And the end result is that none of these bills really went anywhere.
Let me go through just a couple of these just to make sure we've got them all correct. There were several bills that would grant advanced practice registered nurses full practice authority independently. Did any of those pass?
No.
There was another one that would specifically apply to nurses practicing in rural areas or underserved areas. Did that pass?
No.
There was a bill that would allow psychologists to prescribe prescription medications. Did that bill pass?
No.
There was another bill that would have allowed physical therapists to see patients for 30 days without a physician referral. Did that bill pass?
No.
Is this why they call you Dr. No over at the Capitol,
No.
Mr. Finch?
I think that we have evolved beyond saying simply no to any of these proposals, but to taking the proposals very seriously and evaluating them as in terms of the education and training of the practitioners and how it fits best into the healthcare team, as well as the patient safety component of the proposal.
For example, there was a bill that passed that allows APRNs or PAs to sign a death certificate or a DNR order with physician delegation. Is that consistent with the model you're talking about? Actually,
the bill passed to allow only the signing of a death certificate for hospice care. It did not include the signing of out-of-hospital DNRs.
And that's consistent, though, with the delegated model that you were talking about.
100%. There was also a bill that passed out of the House. It was a bill sponsored by State Representative John Zerwas, Dr. Zerwas, who was chair of the Appropriations Committee, but it would have allowed the delegation of Schedule II medications to physician assistants. That bill did pass the House. We were fine with that bill. It was tacked on. It was not passed by the Senate, but was included as an amendment to another bill in the Senate, but ultimately stripped out. I will tell you that in terms of the prescribing of Schedule II medications, more and more physicians, particularly surgeons, are wanting to be able to delegate Schedule II. We don't look at this as a scope of practice increase so much as we view this as a choice, a legitimate choice for physicians to make, because ultimately the choice on whether to delegate prescribing is 100% flexible and is determined by the physician and no one else but the physician. A physician can limit the delegation of prescribing to a physician assistant or an advanced practice registered nurse to include everything up to Schedules 3, 4, and 5, as well as other drugs, or can be limited in any way in terms of whether they delegate prescribing privileges at all or just a limitation on the kinds of pharmaceuticals that they will delegate to.
Speaking of prescribing drugs, we came into this legislative session expecting to face a mandate that all prescribers and all dispensers of controlled substances were going to have to check the Prescription Drug Monitoring Program,
right,
or PDMP, which was recently moved over to the Board of Pharmacy, but they were going to have to check that every time they wrote a controlled substance. And I realize that the opioid epidemic is a concern across the country. Texas, luckily, has some better statistics than a lot of other states. But this was the proposed response: was you've got to check for doctor shopping, you've got to check for inappropriate prescribing before you write every single prescription.
Right. Most of this discussion on mandates to check the prescription monitoring program at the Board of Pharmacy started in the sunset review process in the fall. Where virtually all the health licensing agencies were up for sunset this year. The sunset was recommending a mandated check of the prescription monitoring program before issuing any prescription for a controlled substance, and for a pharmacist to check before filling any controlled substance. We went to the legislature beginning, actually before session, and we're promoting basically a technology solution.
Well, before you, how many prescriptions are we talking about?
The numbers I saw from the Board of Pharmacy indicated that it would require physicians to check before writing a controlled substance, and a pharmacist to check before dispensing, in the order of 3.3 to 3.5 million prescriptions per month.
Every month?
Every month.
So we had a better idea.
Our idea and our proposal was to let's use this technology that resides at the Board of Pharmacy with the prescription monitoring, and use it in this manner. Number one, to give the boards the specific authority to push out notifications to prescribers and dispensers, pharmacists, when certain individuals meet a criteria that looks to be doctor shopping.
So this is an electronic that looks for something fishy.
Well, through the monitoring program, remember, the pharmacists report the data on controlled substances. The board assembles this in the monitoring program and has the ability to push out notices and to basically do an electronic scan of prescribing. And the criteria that they've chosen are 5, 5, and 5.
And what are those 5s?
If I get 5 different prescriptions from 5 different, for controlled substance, from 5 different physicians or 5 different prescribers, and fill them at 5 different pharmacies in a 30-day period, then everybody who wrote me a prescription or filled a prescription will get an alert through the electronically through the prescription monitoring program to say, not that I'm doctor shopping, but you perhaps ought to look more closely at your prescribing practices for this individual or your dispensing practices because this looks a little awry. And I think at the first test run the board did in January, identified some 130 individuals who fit that criteria. Now the problem is that in pushing out these notices, it depends on everybody being registered with the system. And so while the board identified 130 some odd instances that met their criteria, 555, they only pushed out about 250 notices, and that is the registration numbers. And so what we've been promoting, in addition to the explicit authority to do this scan, is that we would automatically have the licensing boards for all prescribers automatically register with the PMP their licensees who can prescribe. So all physicians, all dentists.
So that those holes go away.
Those holes begin to go away with that automatic registration. That's one piece. The other piece of this has to do with reports that wholesale deliverers already file with the Drug Enforcement Administration, DEA in Washington, on where they're actually delivering product. And by allowing the Board of Pharmacy access to those same reports, those reports can be rinsed through the PMP to determine geographic anomalies in dispensing and delivery. So that if we know that in a certain area of our state, perhaps a zip code, that 20,000 hydrocodone, for example, are being dispensed per month, and yet the delivery data shows that 40 or 50,000 units are coming in, that's not an allegation of diversion, but it is a data point that someone should be looking at, like the Board of Pharmacy, to explain why there are these anomalies.
Well, where did those 20 or 30,000 units of hydrocodone go?
Exactly.
The legislation that passed reinforced those principles, but
yes.
They did go a step further, but we made sure that that was a step we won't see for a while.
Well, they quickly adopted our proposals on the technology solutions, but still imposed a mandate to check. On the other hand, the mandate to check is not effective until September 1, 2019. So there's an entire interim that we will go through leading up to the 2019 session, where there will be studies on the effectiveness of push-out notifications, automatic registrations, and the determination of these geographic anomalies, as well as another full session in the legislature to look at the success what kinds of additional measures do we need to take, and we can even come back and address the mandates, which will not be effective until after the next session.
After the 2019
After
session.
the 2019 session.
All right. Speaking of after session, one of the important things that the legislature did not complete was the sunset review and reauthorization
Right.
of the Texas Medical Board and the Texas Medical Practice Act.
Sunset is a process where we look at every state agency on a schedule every 12 years to reauthorize those agencies. And it becomes both an administrative and political issue during the session. And this was the year, this was the session that all the health licensing agencies were up for sunset, and included in that is the medical board. So not only did the sunset bill for the medical board die in calendars committee, but also the safety net bill was never considered on the floor of the House prior to the deadline.
In addition to simply extending the date and reauthorizing an agency and its underlying law for a dozen years or so, sunset's an opportunity to improve the way the agency works, right?
Absolutely.
And if I recall correctly, one of the issues we were really working hard in terms of improving the medical board was how it handles complaints against physicians and the due process protections that it gives to physicians who are accused of complaints. We covered that issue in Texas Medicine late last year, and we had a number of that pieces of language getting ready to go into the medical board sunset bill. Would it be open to considering those protections again?
It really is going to depend on how broadly or how narrowly the governor's call is issued. Sunset for us in general, and the Medical Practices Act in particular, and the medical board, presents both opportunities and challenges. Besides just the sheer challenges of moving the legislation through, the opportunities are how do we improve due process protections. We had some other specific recommendations on automatic and more expedited appeals to the SOA process, the State Office of Administrative Hearings process, when the board revokes a license on an emergency basis. And we also had some legislation and proposals related to fairness and whistleblower protections for physicians who are employed by 501A organizations. All of those went away at the end of this regular session. All of those we hope will be in play in a special session where we take up sunset for the medical board once again.
And if not, we'll be back in 2019 with those issues all over again, right?
It is an ongoing process.
It's always an ongoing process. Well, Dan, thank you very much for joining us, and good luck in the interim, because it sounds like you've already laid out quite a bit of work to get done.
Thanks again to Steve and Dan for joining us. Of course, Governor Greg Abbott called a special session starting July 18th to address the TMB Sunset Act along with several other issues. Up next week, our final installment in our regular legislative session wrap-up series. Troy Alexander, also of TMA's advocacy team, will join us to analyze some of the items he worked this session, including public health, children's health and safety issues, and more. Question: did you miss our earlier legislative summary videos? If so, please check out TMA's YouTube channel for more details of what passed and what didn't this session. Our experts covered the budget, insurance issues like balance billing, maintenance of certification, and more. That's it for this week. I'm TMA's Brent Anier. Thank you for watching, and please join us again next week for a final legislative wrap-up on TMA's Legislative News Hotline.